is on. Everyone is there. Okay. Hello, everyone. Well, thank you for coming back to us. We know that our November batch have already done the exam, so we just want to say congratulations. That's at least a relief that you've done the exams. Hopefully you've passed. We're very confident you have, but we would just like to tell you, take it easy from now. You're not watching this because you don't want anything to do with exams. Today we're going to talk about Perthes disease. We have Nikki Walsh who's recently passed exams as well. She's going to talk to us about Perthes disease. Some of her talk is based on international standards, and of course, if there's something from the UK, we'll point it out as well. Nikki, thank you for joining us. Would you like to go ahead?
Yeah, sure, Swan. I'd also like to say that, you know, some of my talk, I've put my disclosures in there, but I did work with Dr. David Little, who is a very big pediatric surgeon in Australia. And he's done a lot of work on Skiffy and Perthes. And part of my talk is related to his recent evidence. And if you are interested, I can give you the scientific evidence. You know, but, you know, obviously we're looking at this as part of an exam. So we're going to try and focus on what you need to talk to about the exam. So, my disclosures are that I've looked at the leg calvé Perthes disease. I used a JOS article that was in 2010, which has got some really nice pictures in. And if you want a copy of that and you don't have access to it, I do have access to it, and I can send that to you. And the other part is the book, which is the Postgraduate's Guide to Pediatrics, which is from University Press. Right? It's very good. It's very good summary of what you need to do, what you need to talk about. And it's good. And a lot of my pictures are taken from that because I think it's important. So what is Perthes disease? And the problem is that Perthes disease is kind of it's an avascular necrosis of the femoral epiphysis, so the femoral head. It tends to be more common between children between the age of 5 and 7, but 4 to 8 is also recognized. If you are in the population that's over 8 years old, you're probably likely to develop post-traumatic arthritis, which may require surgery. And the goal of treatment is to try and minimize the head deformity and the amount of excrusion that we may see in Perthes. So the etiology, I think this is difficult because we don't know. We don't know what it causes, right? There's 3 theories. So one is the anatomical theory, which in my opinion, I think makes the most sense. And you got the hydrostatic and the thrombophillic theories, and then you got other factors. Right? So for me, the anatomical theory makes the most sense. So you've got a blood supply to the femoral head, which changes as you grow. Right? So you guys, the thing is that the contribution from the lateral femoral circumflex artery is important in developing. So in the adults, it's not necessary, right? But in the earlier stages, the contribution of the lateral femoral circumflex artery, which is a branch of the profundus femoris, is really important. So if you look at the rest of it, right, I've put there in the table there, right, the other consumers, but you've got to think about the lateral femoral cutaneous, and that's important in the next slide, because why do you get Perthes? You get Perthes in people that are delayed in their bone development. So typically 2 years for women and 2 years for, 1 year for men. So the point being that their cartilage, their ossific nucleus is not developing because they've got delayed bone age, but their cartilage is developing because you've still got feeding from the synovial fluid. So here's where the importance of the lateral femoral circumflex comes into union, because we're going to have that changeover. We're going to have a changeover from the lateral femoral circumflex, medial femoral circumflex, and you've got femoral head that is a bit delayed in developing. So your difference between the bone and the cartilage elements is increased, right? So your medial femoral circumflex arteries, which should be dying off, right, can't bridge that. And your lateral femoral circumflex arteries, which should be taken over, right, have not quite taken over because this area is too big for them to bridge, right? That's why you get Perthes, or at least one of the reasons why you would think about it. Other things. So I think what I've just told you is probably the main reason. But we need to know about other things. So one of them is the hydrostatic pressure. So increase in intraocular pressure causes a reduction in blood supply, which would cause a reduction in blood supply from the lateral interosseous artery. And Thrombophillic theory, which is that kids with sickle cell and thalassemia do show an increased incidence. Maybe do that. Maybe it's not. I don't know. We don't know. We don't know. We know it's a place that we can look at. So other factors, so trauma, hypermobility, attention deficit disorder, susceptibility, no growth, low birth weight, low size. So, right, the point of this is that if you have a patient that has Perthes disease, they have this increased area of cartilage as opposed to bone. So if you have any of these other factors, right, then it's going to promote more deficiency. So if you've had, so as we've already said, if you've got a low birth weight, right, so say you're still trying to grow, then cartilage grows. It's not as hard as bone. It's going to promote a problem, right? So presentation. So you're looking at kids that come in, right? So most of them have a limb, right? They might have thigh pain. They might have knee pain. And Why do they have knee pain? They have knee pain because the femoral and the obturator nerve supplies both the hip and the knee. So they can have hip or knee pain, right? So if you see a child that has knee pain, you need to look at the hip, right? It might be activity related, it might be acute, and it might be a symptom of minor trauma. What do you find in examination? So in the early stages, it might be normal, but in the later stages, they do have limited range of motion, especially abduction and interrotation, because of the deformation of the femoral head. They might have an antalgic gait. They might be trend element positive. They might have muscle spasm or atrophy from the disease. They might have a leg length discrepancy because of the collapse of the femoral head. And you need to look at these kids and see, right, do they look normal? Do they have any other features of developmental dysplasia? Is it an isolated lower limb discrepancy, or is it something else? That's what you need to look at. And I would say you need to look at things like Thomas's test, Galeotti's test, Trendelenburg test. You need to look at that. Do true and apparent leg length examination. What are we going to do? So we're going to look at this kid. We're going to make sure there's no cervical arthritis. And then we're going to look at x-rays. I'm going to do AP and Fogler's actually. Right? And we're going to look at, we're going to look for DDH and subcameral femoral epiphysis, right? But they are outside of our group. We're going to look at it anyway. In our group, we're going to be looking for Perthes. So we're going to be looking at widening of the joint space. And the reason you get widening of the joint space is because you get hypertrophy of the ligament anterior. Right. You might see that. You're going to see a smaller femoral epiphysis because it's not developing because it's got AVN. Crescent sign, which is subchondral fracture, you might see that, and flattening of the epiphysis. And the thing that is going to give you the right, the most reliable thing is going to be an MRI. So you need to consider septic arthritis. In any of these things, you need to consider septic arthritis. So unilateral Perthes disease, you need to consider septic arthritis. You need to consider sickle cell disease, which will give you ABN. You need to consider something like an eosinophilic granuloma. And you need to consider septic arthritis. Now, differential of bilateral. So typically, Perthes disease does not give you the same findings at the same time. It may give you Perthes in one hip and then maybe 12 months later in another hip. If you see bilateral Perthes, you need to consider multiple epiphyseal dysplasia. Right? You really do. You really do. Because Perthes doesn't do both at the same time. Even secondary to steroids or chemotherapy, it doesn't do it at the same time. So if you see bilateral Perthes at the same time, you need to consider these are the prognoses, and the most common would be multiple epiphyseal dysplasia. So when you're looking at Perthes, there's several classification systems, right? So the first one is Waldenstroms, which is based on radiographic changes. And the radiographic changes are based on the fact that you've got a repeated infarction of the bone followed by fracture. So stage 1 is the initial and the sclerotic stage. Number 2 is the fragmentation stage. Number 3 is Re-Ossification, and number 4 is remodeling. So let's have a look at that. So in stage 1, you've got a sclerotic and necrotic stage, right? So you've got bone ischemia, which leads to necrosis. The esophageal nucleus is not growing because of AVN, but the cartilage is growing, right? So you get widened joint space, and you get sclerosis of the ossific nucleus. And this typically lasts between 6 to 12 months. When you get to stage 2, right, you're starting to get revascularization. So you're getting this uncoupling of bone formation and bone resorption, just almost like Paget's. Okay? But you get this, you get these fissures in the bone because the bone is reabsorption, but because it's uncoupled, you're not quite getting the reabsorption straight away. And this is the area where you're going to get a lot of deformity. You see something like this, which is reabsorption, right? Stage 3 is where you're getting vascular degeneration, right? It starts initially peripherally and it progresses centrally. So it goes posterior to anterior and lateral to medial, right? So what you're seeing is the sclerotic area is being resolved, and you're starting to see a little bit more of the femoral head. And again, this lasts about 6 to 24 months. And then the remodeling stage is when you get healing of the bone. So the bone, it reabsorbs. So the sclerotic and the radiographic changes start to return to normal. You get a femoral head that looks almost normal, but it may have deformation, it may have some of the changes that we'll talk about. So one of the things is a large head, it's cochlear magna. You might have a wide short neck, which is coxa breva. As you get older, the remodeling phase is less good. So if you diagnose Perthes in a 5-year-old, it's probably going to be a good outcome. If you diagnose it in a 9-year-old, it's going to be a less good outcome. And the other part is the acetabular remodelization. So the acetabular probably remodels up until the age of 7 or 8. So if you've got a young child, the acetabulum will remodel. If you're diagnosing Perthes in a 9-year-old, the acetabulum probably won't remodel. So classification, there's 3 classification systems, right? And so there's probably 4, actually. So one is Lateral, done in 1971. I've not touched on it. Sultan Thomas, 1984. Again, I've not touched on it. The Herring classification of lateral pillar is probably the one that is most prognostic. So we will talk about that. And you need an AP pelvis to compare it with the other side. And then the next one is the Stulberg, which is more of a long-term classification. So for the purpose of your exam, know these exist, but you want to focus on the herring, right? So here is the herring. So the herring is based on what happens to the lateral pillar. So herring type A, the lateral pillar is null. In herring type B, I think I've actually put that wrong. I think herring type B is more than 50% of the lateral pillar is maintained, and type C is less than 50% of the lateral pillar maintained. So a BC is that you've lost your lateral pillar and you've lost your central segment as well. So the point being that BC may be worthy of treatment. So poor signs are the fact that if you're female, so Perthes is 4 times more common in men than women. So if you're a female, it's bad, right? If you're older, yeah, that's bad. If you're fat, yeah, not good. If it's bilateral, I'd say it's probably not Perthes disease if it's the same stage, but if it's different stages, that's bad as well. And stiffness because, you know, how are we going to get over this? So let's look at some of the things. So one of the things you'll come across in your exam is this is Catterell's head at risk signs. And even though I've not gone through Catterell's classification, because I don't think it's necessary, these are the head at risk signs that I think you probably should know. So one of them is Gage's sign, and what that is, it's a V-shaped lucency in the lateral epiphysis, which I'll show in a sec. Lateral calcification, lateral to the epiphysis, which implies a loss of the lateral support. Lateral subluxation, again, similar, implies loss of support. If it's more than 3 millimeters, we'd be concerned. Horizontal growth plate, well, generally the growth plate is about 45 degrees. If you have a horizontal growth plate, it kind of makes you think, well, is there a problem with the growth plate? You know, we'd have to look at that a bit further. And metaphyseal rarefaction or cytic chain. So it changes in the metaphyseal part of the femur. So this X-ray shows this is Gage's sign, right? You can see someone's taken a bite out of the lateral femoral epiphysis. And if you look at the other side, you can see subluxation of the femoral head. Yeah. So what are we trying to do with Perthes? So we want to try and prevent deformation of the femoral head. It's not always possible. We want to try and prevent extrusion, minimize enlargement. We want to prevent GT overgrowth. Because what happens with the GT, I think I've put this further down, but what happens is your capital growth plate stops growing and your GT growth plate keeps growing. So you get this whole concept of GT enlargement, right? So we're going to have a look at that in a sec. So are we going to operate on them? Well, it depends on what their radiographic stage is and what their clinical symptoms are. So management. The management is always controversial. And I think you need to say that. I think in your Viva, you need to say, look, management of Perthes is controversial, right? You need to say it, because what I'm about to say next is not definite. It's a summary of what I've been taught, but it's not necessarily what I do. I would always speak to a pediatric place to decide whether the treatment's appropriate or not. So this is just a summary, and I would say you need to talk to someone else in pediatrics, but it's just something to think about, right? So, as I said, your management is going to be controversial. Your aims are to preserve the range of motion and maintain the coverage of hip and limit deformity. So, limitation of weight-bearing activities. So, you know, in the fragmentation stage, which is where most deformity happens, possibly we should limit their weight bearing. Probably should put on crutches. You know, maybe we should do that. I don't know of the evidence for this, but that's probably something I would consider. Crutches, same reason. Physio, right? You want to maintain their range of motion. Again, same reason, limit their activity, maintain the range of motion. Abduction braces and orthoses, that's because they tend to form an adduction deformity. So should we splint them in abduction, put broomstick casts on? I don't know if there's a lot of evidence to convince that, but it's something we should consider. Containment and salvage. Right, so weight bearing, we've discussed it. I don't think there's very much evidence to say that we should weight bear them or not weight bear them. I don't know, to be honest. Bracing, casting, broomstick cast, again, I'm not sure. I don't know. I don't know if we cast them in abduction and external rotation. Does that make a difference? I don't know that there's very much evidence to say it does. Surgery is containment versus salvage. So your containment surgery options are going to be a femoral osteotomy, a varus extension osteotomy, a shelf, or a redirectional. And the best results are done in patients who are overweight with herring B or C, because herring A and B are probably going to be okay with an operative treatment. Herring C, it's not going to make any difference. So the only time you have to act is the herring B and C, right? Does it make a difference? I don't know. Let's look at it, right? So containment, let's have a look at containment. So your options are a femoral varus osteotomy, right? So you put the hip in varus to put it back in the acetabulum. Pivotadesis of the GT to prevent growth. Yeah, you can do that. Yeah, I can say, I don't know what the evidence is for it. I worked in Sydney Children's Hospital. I never saw it, but it's there as an option. Proximal femoral Valgus Osteotomy for hinge abduction. Well, the point of hinge abduction is that in abduction, it hinges on the acetabulum. So the point of doing a valgus osteotomy is to put the hip in a better position so they don't get hinge abduction. Triple pelvic osteotomy, yeah, vestral, yeah, you know, it's fantastic. But it's a big operation, right? It's a big operation. Is that really where you want to go? I think you need to talk to the family and the surgeons about that. It's a triple pelvic, so it's going to be a redirectional osteotomy. It's going to involve 3 cuts in the pelvis and redirectioning the acetate. Shelf involves taking a bit of the pelvis and putting it on the top. Don't know if that's necessary. So salvage. So valgus intertrochial. So if you got the hinge abduction, this won't work. Shelf osteotomy with joint distraction. So this was popularized a while ago. And you use an X-fix, and you put an X-fix in the pelvis, and you put an X-fix in the proximal femur. You distract the joint. And the short-term results were quite good, but apparently the long-term results didn't show any difference. Arthrodesis is fusing the hip. So it's good in young patients, but you're fusing the hip in a position that's slightly adducted and 30 degrees of flexion and maybe 15 degrees of external rotation. And yes, that could work as far as pain relief goes, but if you're looking at that in a female patient, she can't go to the toilet, you know? So you may be looking at the next option, which is a total hip replacement. And yes, we understand doing a total hip replacement in a patient in their 20s has its own problems, but it may be a better option than an arthrodesis. So doing a hip replacement in a 20-year-old, right, they're probably going to need to have a revision. We're probably going to use, we're not going to use metal on metal anymore these days. We're going to use ceramic, right? But they're going to need to have revision surgery at some stage. So this is going to show hinge abduction. So in the normal hip, this is where we are. Axial rotation. So in hinge abduction, because you get enlargement of the femoral head and overgrowth of the GT, you're going to hinge here. You're going to hinge on your abduction. So what are we concerned about? So you've got a young person who has Perthes disease. What am I concerned about? I'm concerned about their age. So if they're a little bit older, I'm more concerned about a femoral head deformation, and I'm more concerned about how severe the disease is. There's less option for remodeling in the older child. Right. Epiphyseal involvement, right? If the whole epiphysis is involved, it's going to have a poor outcome, right? If it's a younger child with a more progressive disease, then we have to look at the other options. And then, you know, is the femoral head extruded? If it is, that's bad. If it's an older child, that's bad as well. We need to think about that. So, in a kid under 5, you know, this is going to be good, right? Kids under 5, there's a lot of potential for remodeling. So, do they have any epiphyseal involvement? No strain of the hip. 1, 2, 3. No, I wouldn't involve them. We just review them, right? If they're under 5, but they have more significant changes, we might consider a brace. We're still not in the surgery stage because this kid's going to do well, right? Under 12, right? Okay, you're not doing well. So you've got an epiphysis. It's not getting extrusion, but it's quite far in the disease. So we're going to keep an eye on it. 5 to 7, you're in that middle bit, right? might consider some surgery. 7 to 12, oh God, you're in that bad stage. We're going to consider some surgery. 7 to 12, with a lot of changes, yeah. Maybe containment is out of the question. We might be going for salvage. And there we go. Hinge abduction. Right? We need to think about that. So the Stulberg classification depends on the congruency. And I've summarized this. So there's about 5 or 6 stages. But for me, I think, we can put it into this way. So 1 and 2 is that it's spherical. Arthritis doesn't develop. 3 and 4, yeah, you might get arthritis. 5, you're going to get severe arthritis. And that's what I would do. And you can look at my lecture notes to further identify this, but I think generally, talking an exam, this is what you would do. So for the purpose of the exam, I'm not described all the surgical techniques, but I can do. Perthes treatment is very controversial. And I would recommend that you say, I would discuss this case with a pediatric orthopedic unit. And you would say, right, okay, it's this stage. I'd think about an operative treatment. I might consider, containment or salvage, but I would discuss it with an orthopedic unit. And I think that is a safe thing to say for your exam. This is the course that me and Hussam are doing this year. Welcome. Come and join us. Right, thank you. Any other question?
Thank you very much, Nikki. So far we've discussed Perthes. Kashif Mamoon is one of the mentors who's joined with us. I'm sure he's listening. It's just he's off camera at the moment. The couple of things, guys, just to remind you, yes, this is absolutely correct. It is a controversial subject because we're not 100% sure about the exact treatment pathway. There's no doubt the majority of patients are just going to need observation. When you need to intervene is one of the questions, and where and what intervention will you do is another question. So the approach to this is to develop a pathway in your head. What are you going to do for a child that is young and has a significant Herring's classification, as in a C? What are you going to do, or with a BC? What are you going to do with a middle age, as in somewhere between 5 and 8? What are you going to do with that child on initial presentation? And what are you going to do with each of these versions of the Herring classification from A, B, C, A, B, B, C, and C? How are you going to manage? And finally, the patient who is older and or delayed presentation patient who has clinical symptoms and severity, which shows that the head is not encapsulated and not, or is an hinging, or there's already a tabular remodeling which is causing problems for later on in life. So these are, if you develop those scenarios in your head and have an answer for them, you don't have to be very accurate or very in-depth in your answer. It's just understand that each patient has a different pathway in how you're going to manage. Yes, the majority do require observation. How frequent is your observation is often a question they'll ask you. What are you looking for? What are you waiting for in your observation? And what about your clinical examination? What's your clinical examination going to involve? So people always talk about the x-rays and what they're looking for, but clinical examination is also quite important, as mentioned by Nikki again. So you need to have a think about what are the clinical factors that would indicate that you need to consider intervention or not. Okay. Before we go on to Viva questions, anyone got any questions here?
Look, I think, Sean, the treatment of Perthes disease is very controversial. And I think that for most exam candidates, it would be enough to recognize the stages and what the possible complications could be.
Yeah.
Without having to explain the treatment, because the treatment is very controversial. You know?
Well, the treatment principles, Nikki, is probably what they're going to look for. So I wouldn't say you need to know how to do each operation, but you do need to understand the principles of containment. And remember, treatment doesn't necessarily mean always surgery. So containment, observation is also treatment.
Yeah. So one of the cases I wanted to, I was going to present, but I've not done it, is I had a 4-year-old last week who presented with a limp, right? No fever, no family history of anything, presented with a limp. He's 4 years old, so he's a little bit on the downside of Perthes. But he did have some indication that his specific nucleus was not forming the right way it should do. So in that case, I would say we need to observe this child, right? We know the prognosis is going to be good because he's young, but we need to observe it.
Absolutely correct. So the scenarios in this exam are not going to be straight away, tell me about Perthes. That's not the way they're going to ask this question. They're going to give you a case like that, a 4-year-old limping child, or usually it will come up as either limping child or part of a differential diagnosis. It's very important you don't leap on Perthes no matter what the age of the child is, because there are other diagnoses which are much more devastating if you miss them in the initial stages than if you outrule them first and then go to, well, now we've excluded everything else, let's think about Perthes. Does that make sense, guys?
One of the things I wanted to say, it was very much apparent in the Australian training system, it doesn't seem to be that much in the UK training system, is the fact that you can get bilateral Perthes. Now, normally, you don't get bilateral Perthes at the same stage. If it's truly Perthes, you've got to think of multiple epiphyseal dysplasia. That was one of the things that came up really highly in my Australian exams, but maybe not so much.
Okay. And absolutely right. And also the other way that they can ask this is you're seeing the patient after a diagnosis of Perthes has been made, and the mom now wants to know what the chances are for their child, or what is Perthes. Mom wants to know what is Perthes. So you need to be able to explain its etiology, its diagnosis, its risk of inheritance, which there is a connection with family history, but not necessarily an inherited risk. And also the other factors associated with it. So these are all conversations, and also the prognosis for this child and so on, and what might happen in their adulthood. So these are all the way those questions, the Perthes, can be brought up without actually talking about doing corrective surgery to maintain containment and things like that. Okay, so it does come up in the exam. I do appreciate it as a controversial one,